The vast majority of DCIS is not palpable, and traditional imaging, it doesn't capture DCIS as well as it does invasive cancer.
We don't have a good tool to understand what the area of DCIS is preoperatively, but the MarginProbe helps us to save a re-excision, to achieve clear margins in these cases, because it can tell the extent of the DCIS better than the human eye, better than the imaging studies that we've had going into the operating room.
DCIS is a problem both in the setting of pure DCIS and in the setting of invasive cancer. There's a concept called extensive intraductal component, and that means you have an invasive cancer, but you also have a lot of DCIS associated with it. So whenever we have that, we always worry about our margins. DCIS can be the hardest thing to get clear of your margins, whether you're operating on someone with pure DCIS or someone with invasive cancer.
I don't know if the stakes are higher. I would say I think it's just harder for the surgeon to get out the cancer the first time when dealing with DCIS. And that's in paper after paper. So it's community surgeons, academic surgeons, we just have a more difficult time. So you may think you've gotten it all, and 6 millimeters beyond it is another area of DCIS.
I have a patient who I had to take to another hospital because she has different insurance that I couldn't use at the hospital that has the MarginProbe. And I wished I had it. And in fact, her 1 centimeter invasive cancer was very nicely in the middle of that tissue that I removed. But I had multiple positive margins for 3.9 centimeters of DCIS. And you kind of go over it and say, what could I have done differently? What could I have done better? I think to myself, if I had only had it, it would have most probably prevented me from going back.